Imagine experiencing like a severe life-altering pain during just a completely routine
You're
activity.
right, like something totally mundane.
Yeah, exactly. Trying to use a tampon or just sitting at your desk or, attempting intimacy. And you finally go to the doctor, completely desperate, only for them to look at your test results and say, well, everything is normal. It's all in your head.
Ugh. I mean, it is the ultimate medical gaslighting.
It really is.
We know provoked vulvodynia, or PV, has been steeped in these sort of diagnostic muddy waters for decades. But today, we are zeroing in on a highly specific structural subtype. It's called Neuroproliferative Vestibulodynia, or NPV.
And we've got a really massive stack of sources for this deep dive today. We're pulling from histological research from the Dove Medical Press, papers from Pelvic and data from the clinical trial NCT 0725702 on topical ketotifen.
Plus the clinical guidelines from the Royal College of Obstetricians and Gynecologists, right?
Yes, exactly. And some fascinating insights detailing how this whole mechanism actually connects to endometriosis.
So our mission for this deep dive is to answer one fundamental question. What is the exact role of localized mast cell activation and degranulation in the pathogenesis of this condition?
Because it's not just a mystery pain.
No, not at all. We're going to look at how these tiny immune responders act as rogue architects. They are literally rewiring the local nervous system. And understanding this, this cellular chain reaction is the ultimate key to validating the pain and, more importantly, figuring out how to intercept it.
Let's get right into the tissue then. I mean, we know the hallmark of PV is allodynia.
Right, that severe mechanical hypersensitivity.
Yeah, but what is really fascinating is looking at the actual physical architecture causing it.
Definitely. So when we look at the neuroproliferative subtype, NPV, it generally presents in two distinct timelines. You've got primary and secondary.
Okay, so break those down for us. Primary means it's always been there.
Pretty much. With primary NPV, you're looking at a congenital issue. A patient has lived with this penetration pain their whole life. They often realize it the very first time they try to use a tampon or during a first pelvic exam.
Wow, okay. And secondary?
Secondary NPV is acquired later. So a patient has a period of completely normal, pain-free function, but then a specific event triggers the condition. Usually it's like a recurrent yeast infection, a severe allergic reaction, or maybe repeated exposure to some topical irritants.
Yeah, what's wild is when researchers actually take biopsies of the vestibular tissue from patients who undergo surgery for this pain, they don't find normal tissue at all.
Not even close.
The density of the nerve fibers in the vestibular stroma of women with PV is like a staggering 10 times greater than in non-affected women. 10 times.
I know, it's a massive increase. And it's not just the sheer volume that's staggering, it's the location. The location of these nerves is completely aberrant.
What do you mean by aberrant? Like they're growing in the wrong direction?
Exactly. These nerve fibers have proliferated so aggressively that they actually penetrate the basal membrane. They just keep growing vertically, reaching almost to the very surface of the epithelial tissue.
And they aren't supposed to be there.
Right. Normally, those superficial layers should be relatively free of these dense, highly sensitive nerve endings.
So if we think about this in like everyday terms, if you're listening, it's kind of like a home security system. Imagine you have this tiny narrow hallway and the installers accidentally put in 10 times too many motion sensors.
Oh, that's a good way to look at it.
And instead of burying the wires safely behind the drywall, they wire them right up against the wallpaper. So now the slightest breeze, a shadow, literally a speck of dust, it sets off this massive, deafening alarm.
That is exactly what is happening physically in the vestibule. The structural alteration is totally undeniable. But, biology doesn't just build new nerve pathways completely randomly.
Right, it takes energy to do that.
Exactly. The body is highly efficient. To get 10 times the normal nerve density growing into spaces they absolutely do not belong, there has to be an active construction crew forcing that growth.
Which brings us to the core focus of this deep dive, the mast cell.
Yes.
Now, since we're diving deep into the pathogenesis here, we know mast cells are primarily immune responders, right? Like for allergies.
Mostly, yeah. They are the classic allergy cells. But the biopsies from NPV patients show this massive accumulation of clustered, highly activated mast cells parked directly in the vestibular mucosa.
And they aren't just sitting there minding their own business.
No, they are highly reactive. When an environmental trigger happens, say the recurring presence of candida during a fungal infection, these mast cells undergo what we call degranulation.
Degranulation. Okay, so what does that actually look like?
Well, degranulation isn't just a simple release of a few distress signals. It is this highly coordinated, rapid cellular response where the mast cell discharges a massive payload of mediators. It basically dumps its internal granules directly into the surrounding tissue.
And looking at the sources, the chemical cocktail we're talking about includes histamine, tryptase, bradykinin, and most notably, an enzyme called heparinase.
Heparinase is the absolute crucial mechanism here. It's an endoglycosidase.
Which is a big word for.
It's an enzyme that specifically cleaves heparin sulfate. But in plain terms, heparinase degrades connective tissue. It actively breaks down the epithelial basement membrane. It functions as like a molecular bulldozer.
Okay, wait, I want to challenge this mechanical process for a second. If heparinase is literally destroying the connective tissue and bulldozing the basement membrane, why doesn't the tissue just, like, fall apart?
That's a really valid question.
Right, because how does the body sustain that level of biological demolition without showing visible ulceration or severe tissue damage when a doctor just looks at it during an exam?
And that right there is the paradox of NPV, and it's exactly why doctors miss it. The degradation is highly localized and microscopic. Heparinase isn't melting the entire tissue structure all at once. It's creating microtunnels. It digests just enough of the extracellular matrix to clear a microscopic path.
So it's essentially unlocking the biological doors that usually keep nerves confined to the deeper stroma.
Precisely. So to the naked eye, the surface looks completely intact. But structurally, the scaffolding underneath has been totally breached. This microtunneling is what allows those newly proliferating nerve fibers to physically invade the surface epithelium.
Okay, so the mast cell uses heparinase to clear the physical path. But just clearing a path doesn't force nerves to actually grow into it. There has to be something else, like a biological fertilizer pushing that hyperinnervation.
Oh, there is. That fertilizer is nerve growth factor, or NGF.
NGF.
Yes, NGF is another major component of that mast cell degranulation payload. And it's also synthesized by local stromal cells and the neurons themselves when they are under stress.
So it's coming from multiple angles.
Right. NGF is a neurotrophin. Its entire evolutionary purpose is to promote axon sprouting and ensure the survival of neurons. When the mast cell dumps NGF into this newly breached environment, it's essentially pouring a high-grade fertilizer onto aggressive weeds.
But NGF doesn't just make the nerves grow physically longer. Looking at the Dove Medical Press research, it fundamentally changes how these nerves behave at the membrane level, doesn't it?
It really does. It rewires them.
Because NGF rapidly increases the membrane expression of specific ion channels on these newly sprouted nerves, mainly TRPV1.
Which handles heat and pain.
Right, and TRPA1, which handles mechanical pain.
Mechanically, what NGF is doing is lowering the firing threshold of these nociceptors. It makes them completely hyperexcitable. A stimulus that normally wouldn't generate an action potential like just a light touch suddenly causes these pain channels to just burst open.
Flooding the nerve with sodium and calcium ions.
Exactly, and firing a massive, disproportionate pain signal to the brain.
See, here's where the pathogenesis gets terrifying, though. The positive feedback loop.
Oh yeah, the loop is vicious.
It's kind of like a microphone getting way too close to a speaker. The mast cell acts like the singer, releasing the NGF out of the speaker. The hyperexcitable nerve is the microphone picking it up and screaming louder.
Right.
But that increased nerve activity actually triggers the mast cells to release even more NGF.
The loop is brilliantly self-sustaining, unfortunately. The NGF not only sensitizes the nerves, but it also acts as a chemotactic factor, meaning it chemically attracts even more mast cells to the area.
Wow, it calls for backup.
Yes. Furthermore, mast cells actually possess receptors for NGF on their own membranes. So the NGF they release binds back to themselves and stimulates the synthesis of even more NGF.
That's insane.
The biological system just becomes locked in this localized, self-amplifying cycle of neuroproliferation and hypersensitivity.
So this feedback loop perfectly explains the intense localized pain. But if this screeching local alarm goes on for months or years, it doesn't just stay in the vestibule, does it? The central nervous system eventually starts changing.
It does. And to understand this transition from peripheral pain to central pain, the animal model studies in the literature are incredibly illuminating. Researchers simulated this condition by injecting rats and mice with zymosin.
Which is a fungal antigen, right?
Right. Or they used oxazolone to mimic that recurrent inflammatory trigger we see in secondary NPV.
And the timelines from those models are just wild. The researchers found that the hyperinnervation and the extreme hypersensitivity persisted for anywhere from 66 to 135 days after the initial inflammatory reaction had completely cleared.
The trigger was long gone, but the biological alarm was still blaring.
That persistence is the hallmark of central sensitization, right?
Exactly. When you have this massive overactivation of the NGF signaling pathway locally, the sensory neurons are firing continuously. This unrelenting signal travels up the peripheral sensory neurons into the dorsal root ganglia and actually hits the spinal cord, specifically the L6 through S3 segments.
So the spinal cord is just being bombarded with pain signals nonstop.
Bombarded to the point of structural adaptation. The conic signaling literally forces the spinal cord to alter its own gene expression.
Wait, really? It changes its gene expression?
Yes. It begins upregulating sodium ion channels, specifically NaV 1.6 through 1.8, along with NMDA receptors and pro-inflammatory cytokines within the spinal cord itself. So the central nervous system basically lowers its own threshold for pain transmission. The sensation of pain becomes hardwired into the spinal cord's chemistry.
Okay, wait. If the pain is now physically hardwired into the spinal cord's gene expression, does that mean treating the local vulvar inflammation after a certain point is basically useless?
Yeah.
Is it like trying to put out a fire that has already burned down the house?
That is a massive clinical hurdle. Once central sensitization is deeply entrenched, therapies that only target the peripheral tissue often fall short because the alarm system inside the house, the spinal cord, is now generating the alarm entirely on its own, regardless of whether the local mast cells are still degranulating. This is why early intervention is absolutely critical and why understanding the timeline of pathogenesis completely dictates the treatment plan.
So let's look at how medical science actually intercepts this.
Yeah.
Because the research shows we have specific tools targeting this exact cellular text message. Let's talk about ketotifen fumarate, or KF. We know it's an anti-allergic mast cell stabilizer. But mechanically, how does it stop this whole cascade?
Ketotifen intercepts the process right at the degranulation phase. For a mast cell to degranulate and drop that payload, it requires an influx of calcium ions. That calcium triggers the fusion of those internal granules with the cell membrane.
Okay.
Ketotifen functions by blocking this calcium-dependent mechanism. So if you introduce KF early enough, it essentially barricades the calcium channels on the mast cell.
So no calcium influx means the bomb never goes off.
Exactly. It attenuates the NGF spike, it stops mast cell accumulation, and it halts the entire neuroproliferative cascade before it ever reaches the spinal cord.
Which perfectly explains why there is a massive ongoing clinical trial right now, that NCT 072570029 study testing topical ketotifen 0.25% specifically for women with secondary vestibulodynia.
Right, it's a very targeted approach.
And on the flip side of that, we have Roto-8-2750.
Yeah, Roto-8-2750 takes a completely different angle. It is a non-peptide inhibitor of NGF itself. So instead of stopping the mast cell from releasing the payload, it targets the NGF directly once it's in the tissue.
How does it do that?
It binds to the NGF and prevents it from interacting with the TKA receptors on the nerves. By blocking that pathway, it successfully reduces the expression of those TRPV1 and TRPA1 pain channels. It basically cuts the wire between the speaker and the microphone.
That is incredible precision. We aren't just throwing general painkillers at the problem. Researchers are literally building chemical blockers to intercept the exact cellular text messages causing the pain.
It's amazing.
But, we have to look at the reality for patients where the neuroproliferation is already completely established. The pelvic paper is very clear that conservative treatments sometimes have higher failure rates in these specific cases.
Unfortunately, yes. When the nerves have already densely proliferated all the way into the epithelium and the central sensitization is locked in at the spinal level, stabilizing the mast cell is sometimes simply too little, too late.
The structural damage is already done.
Right. In these specific cases, surgical treatment, a vestibulectomy, is often the most successful intervention. The surgery physically excises that hyper-innervated mast cell-dense tissue. You are mechanically removing the faulty, overgrown motion sensors because chemical stabilization can no longer reverse the excessive biological architecture that's already there.
Zooming out from the microscopic cellular level for a minute. If this rogue nerve growth mechanism is happening in the vestibule, it makes me wonder if this happens anywhere else in the body. And looking at our sources, there's a really profound connection between NPV and endometriosis.
The mechanistic parallels between the two are striking. Endometriosis, which is where tissue similar to the uterine lining grows outside the uterus, also involves really aggressive neuroproliferation.
So it's the same mechanism.
Very similar. When the stroma of this endometriosis tissue is stimulated by immune factors, specifically interleukin 1 beta, or IL-1B, it drastically increases its own production of NGF.
So it's synthesizing the exact same biological fertilizer.
Yes, and it promotes the exact same kind of abnormal, hyperexcitable nerve fiber development. Furthermore, biopsies of endometriosis lesions also reveal significantly elevated numbers of activated mast cells.
Wow.
The immune system is acting as the same accidental accomplice. It's using the identical NGF and degranulation pathways to generate chronic pain, just in a completely different location.
If you're dealing with this condition, you really have to realize the precision we're talking about here. Science entirely supports the reality of this pain. Which brings us to the clinical guidelines from the RCOG, Royal College of Obstetricians and Gynecologists, because they mandate a biopsychosocial approach.
The RCOG guidelines represent such a crucial shift in clinical practice today. They explicitly mandate that clinicians must recognize that in many cases of chronic pelvic pain, structural pathology isn't found immediately on, say, an ultrasound or a standard visual exam. But the pain is a documented biological reality.
And the guidelines heavily emphasize checking for comorbidities, right? Things like irritable bowel syndrome, bladder pain syndrome, or fibromyalgia.
Yes, exactly.
Because that central sensitization in the spinal cord we talked about earlier, once those L6 through S3 segments are hardwired for pain, it basically misfires across the whole pelvic region.
It's what we call visceral cross-sensitization. Because the pelvic organs share these neural pathways, a blaring chronic alarm in the vestibular tissue can eventually trigger the bladder or the bowel to start signaling pain as well.
Everything gets tangled up.
Right, and the RCOG strongly warns that repeated, endless investigations searching for a macroscopic structural cause are counterproductive. They just delay pain management therapies and ignore the microscopic reality of the disease.
I really think that is the most validating takeaway from all of this clinical data. If you are listening to this, the science entirely supports the reality of your pain. It is an intensely physical cellular issue involving rogue mast cells, microtunneling enzymes, and literal physical nerve growth. Your body is fighting a microscopic battle that traditional X-rays simply weren't built to see. It was never just in your head.
No, not at all. And when you understand the mechanism, when you know exactly why your body hurts at a cellular level, it provides an incredible amount of validation. It removes that psychological burden of unexplained pain.
So just to briefly bring it all together for you,
Right.
we started with a localized severe pain that for decades was brushed off as being quote-unquote in the head. But by diving into the histology, we found the true culprit, the mast cell.
Yep, the rogue architect.
We looked at how it degranulates, releasing heparinase to bulldoze microtunnels and nerve growth factor to feed invasive nerve growth. We explored how this creates a tenfold increase in nerve density, generating a pain loop that shouts so loudly it permanently rewires the gene expression of the spinal cord itself.
And we've seen how medical science is finally intercepting this, whether that's by barricading the calcium channels to stabilize the mast cells with ketotifen, blocking the NGF signals with specialized inhibitors, or surgically removing the hyperinnervated tissue entirely when necessary.
It's truly a completely different landscape than it was even 10 years ago. But before we wrap up this deep dive, we want to leave you with a final thought to ponder based on everything we've uncovered today.
Yeah, think about this. If a localized allergic type reaction involving mast cell degranulation and NGF can completely rewrite the nervous system in the pelvis, what other so-called unexplained chronic pain syndromes across the human body might actually be driven by these exact same rogue architects?
Right.
Are there other conditions completely unrelated to the pelvis, just waiting for the right mast cell stabilizer to switch them off?